Good evening. Thanks for coming. We are incredibly grateful that you took time of all the things that you could do for the Saturday Night at Academy, and you came out to see our presentation. My name is Michael Singer, and we're going to talk to you today about DME in the real world, past, present, and future. Now we're going to have Charlie change gears a little bit to show you about diabetic retinopathy and show you what's on the horizon going forward in terms of clinical trials.
Okay, data dump is almost done. Hang in there, stretch. If you gotta go to the bathroom, if you wanna leave, we'll be here. Okay, so I'm actually gonna engage my panelists for these next few questions. So here's a case, right? Disaster on the left, remarkably good vision for that sort of an eye. And you can turn this eye into 2032 with anti-VEGF agents. And as you've heard over and over by my esteemed partners, it takes a lot of shots if you're using anti-VEGF monotherapy. That's sort of the take-home of what I've heard so far. And the reality is that that is echoed in every trial that we've seen. So in the Protocol T trial, there's been a tremendous amount of energy and money spent on differentiating the 3 anti-VEGF agents. In fact, they all had an equal number of clinical visits through 2 years of Protocol T. Every single patient, regardless of which arm they were in, on average, it was 23 median clinical visits, regardless of the drug that was used. But then let's look longer. So what happens after the clinical trials? So on average, from Protocol I, patients got 0 injections with ranibizumab in the 4th and 5th years after initiation of dosing. 0. So first of all, we said it takes a lot of shots, and now we're saying in long-term follow-up Protocol I, it takes 0 shots to maintain your DME. So my first question for you, and then I'm actually going to put my panelists on the spot, is do you believe that treatment burden goes down when you're managing DME? That's sort of a critical issue, because if you don't, if you believe the Protocol I data, then really we should stop the conversation, right? Because it's 0 once you get to year 4 or 5, and that's doable for a few years if it's 0 after that. So my answers I give you, and then please vote, are number 1, yes, most patients do not need continued dosing beyond the 2nd year of management. Number 2, yes, but a substantial proportion of patients continue to need dosing beyond the 2nd year. 3, no, most patients continue to need dosing beyond the 2nd year. Or 4, no, patients need more dosing beyond the 2nd year of management. What do you think? Some of these may not be straightforward. I'm curious what you think. What do you guys think? Short answers from the panel?
I think that we have to be very careful when we talk to our patients about that decreased treatment burden. It comes from Protocol I predominantly. And in Protocol I, as I mentioned, patients were allowed to stay wet. 1/3 of patients were wet the entire first year, and not all those 1/3 patients received injections every month. And so I think that it's a little bit misleading when we talk about a significant decreased treatment burden. And Neil presented some of that data today, and it was 9 the first year, 7 the 3rd year. So yes, fewer, but not 0.
Well summarized. So I think the critical point there is devil is in the details. So let's look at other data sets that take us through the 4th and 5th year of dosing. So following RIDE and RISE, a trial beautifully summarized by Sinu, we saw that after the 3rd year, yes, 25% of patients no longer need treatments for DME in the 4th year, but that means that the remaining 75% indeed did need continued dosing, and on average they got about 4 shots in the 4th year. And I absolutely agree with Szilárd that the key here is the way you define retreatment. So the stated goal of the DRCR network is to optimize outcomes while minimizing treatment and minimizing cost. And so they have a caveat in all of their trials where you can stop injecting, despite the fact that there is persistent fluid with visual acuity loss, a situation that I would venture to say no one on the panel actually does in their clinical practice. In comparison, all the other long-term extension trials allow you to continue to treat patients in the presence of persistent edema, and that's why the difference in these treatment dosing. So let's come to a case. Think about how you would manage this, and I'm going to put Sinu on the spot here. So here's a patient that's 21, 25, not happy. You treat them for 3 years, and now they're 20, 25 and ecstatic with very little DME. So at this point, Sinu, what are you going to do? Is this a PRN situation? Are you going to continue to dose them? So far, we're just using anti-VEGFs.
Yeah, I mean, if he is 2025, he's
Happy.
dry and happy, I would start gingerly with a treat and extend paradigm.
Yeah, and so would I. In this case, we actually stopped treatment completely. He got a couple shots over 6 months, and then by the end of the first year, he's coming out into this pattern where he's needing a shot every other month with aflibercept. And I show this case because sometimes people don't believe that you get this recurrent edema once you dry it out. Some people are under this philosophy that once you get rid of the DME and they're totally dry, it's not going to come back. Or if it does, it's going to be slow. In fact, many cases are exactly like this, where you do see this rebound edema if you don't keep them dry. So I agree with Sinu. I think actually treat and extend is a reasonable and my preferred approach for DME rather than PRN. Because you want to avoid these bouncing retinas if you can. And you see this with RVO, but I think you also see it with DME. Okay, so we took this to look at aflibercept long-term dosing instead of just the open-label extension with ranibizumab. So this was the Endurance Phase 4 open-label study assessing the long-term need for aflibercept. And the most challenging part in designing this study is what deserves retreatment for DME. This was a PRN-based retreatment because we were trying to truly assess actual need. Right? For wet AMD, I think most of us in the room can agree that most subretinal or intraretinal fluid involving the fovea needs to be treated and needs to be treated aggressively. For DME, it's a little more vague. And so we define something called clinically relevant DME, which we allow the investigators to define. And I'll ask my panelists this now, but here are some examples on the left that during the trial were determined to be clinically relevant DME. And on the right were examples of a little bit of DME that was not determined to be clinically relevant. So how do you determine, Mike, what is relevant DME that needs ongoing aggressive therapy before you start extending the interval?
So I look at a couple of things. I want to know, has there been change in the patient's vision? I look for visual acuity. I look for subjective vision. And then I look for the amount of fluid, both interretinal and subretinal, that's affecting the center of the fovea. You know, central field thickness, or I call central swelling, I'm obviously concerned about. Paracentral edema, and especially when there are small cysts, I'm not as concerned because it's not like wet AMD over time that we have to get everybody as dry as possible. So again, I think I really take a pretty holistic approach by looking both at the anatomy, the exam, and talking to the patient to figure out where I'm going. Now, obviously, the ones on the left, it's not a decision. The ones on the right, especially when we look at like the third one, you know, and the fourth one, that may be what they're going to get to.
Good. So in Endurance, we saw that on the left of each of this slide, you see the visual acuity gains achieved during the core VISTA Phase 3 trial. And on the right are the visual acuity curves after their Endurance for 2 years. You can see you can maintain their visual acuity gains achieved in the Phase 3 trial with significantly reduced dosing. Same thing anatomically. You're achieving anatomic gains during the intensive dosing during the Phase 3 trials, and then you can maintain those anatomic gains with significantly reduced dosing. So what does that mean? Well, we saw almost identical data here as we did in the open label extension, right? So the open label extension was ranibizumab, and the Endurance trial was aflibercept. This showed 25% of patients did not require retreatment in the 4th or the 5th years, but again, that means that 75% of patients indeed did require retreatment, very similar to the open label extension data in that it was about 4 injections per year is what you need to maintain these dry retinas. So let's look at another case. 2100 at baseline. You treat them again for 3 years. Again, they look perfect. This guy's 20/20. There's no edema on that scan that I can see that's significant, and the angiogram looks pretty good. So anybody on the panel going to actively continue to treat this person on a monthly or a fixed interval? Any takers? Anybody going to switch to PRN at this point? Man, this eye looks great. Okay, that's where we're going to go. So we do that. Don't give a shot for 6 months. All right, we're in the clear, right? Wait a minute, hold on. Don't forget your exam. So on exam, there's no DME, but now the eye is full of blood. Not vitreous hemorrhage, but intraretinal hemorrhage, right? You had no intraretinal hemorrhage when they looked great, and now the DME has not recurred. They're still 20/20. The patient's happy as a clam, but now they got all these spots in the middle of their peripheral retina. So Laura, you were a pioneer in wide field imaging, and you taught us a lot through some of your publications. Is that important?
It is, yeah. I mean, I think that we're moving towards treating diabetic retinopathy in addition to the diabetic macular edema.
So are you going to all restart injecting now?
No, I would not. 2020 eye, I've got a philosophy that you can't make a 2020 patient any happier.
Absolutely agree. But this is, of course, the context of a clinical trial. So what did we do? Well, we retreated this patient. So let's see what happens. So 6 months later, voila, the hemorrhages go away. So it is remarkable how well you can address those hemorrhages. And I think it still is an open question, and I absolutely agree with Dr. Keish and the others on the panel that it's unclear if we should treat these patients, and it's probably out of bounds with clinical standard of care to treat that patient, but many trials are addressing that. And we saw in this trial that you had a dramatic increase in the conversion to PDR, as well as a conversion to severe NPDR, whereas there was a decrease over time in the milder forms of DR. We saw exactly this in the open label extension. About a third of patients are showing worsening of their retinopathy status, despite the fact that they have not had recurrence of their DME. So another question for you in the audience: how often do you follow DME patients after year 2 of management who are stable on anti-VEGF dosing? A is monthly, B is individualized, C is quarterly or more frequently, D is I send them back to their referring physician, or E, annually. 1, 2, 3, 4, 5. Go ahead. If you don't mind voting, that gives us information on what you're thinking. And we have received some questions on clinical trials up and coming, so we'll go through that. So most of you are doing C, quarterly or more frequently. I think that's reasonable, right? I rarely go beyond quarterly intervals on people that look great. Any other comments on that? Great, and I'm going to move ahead. So last section before we get to protocol U. So the future, we've had some questions on this. Let's talk about this. So I think about the future for DME and DR management in 5 buckets. So I'm going to take you through those. And the first, and I think the one that is no longer in the future but is now very much in the presence, is the expanded use for our pharmacologic agents for NPDR treatment. Okay, so what do I mean by that? Well, we learned early on with the anti-VEGFs that you can dramatically blunt the progression to PDR, right? PDR is a devastating form of blindness from diabetic retinopathy, separate than DME, and if you treat these patients with anti-VEGF agents, you dramatically slow the progression to that. And so the question has been, great, anti-VEGF agents work well for that. Can steroids do the same thing? What about dexamethasone implant, Ozurdex? What about the fluocinolone implant, Iluvien? What about cheap triamcinolone? And what about the Register Implant? Well, of interest, which of these agents on this screen was the very first agent to show improvements of retinopathy severity? I wonder what everyone would vote. I won't ask. Well, I'll tell you, it was fluocinolone. Who would have thought, right? The Register Implant. Dean Elliott wrote a very important paper published in 2011, and I quote their discussion here in yellow. To the best of our knowledge, this is the first study conducted involving any inocular treatment that demonstrates a reversal of non-proliferative DR severity. So you hear a lot about the anti-VEGFs doing it, but lo and behold, the steroids can do it too. We saw that then in Protocol I, right? You have Lucentis on the left, you have triamcinolone in the middle, and focal laser on the right. And steroids and anti-VEGF had exactly the same impact on slowing progression to PDR in the DRCR Protocol I. We did a similar analysis using the FAME data set, which again, Sini went through elegantly. We saw that in the control arm, almost exactly numerically, the percentage of patients that progressed to PDR in the control arm of RISE and RIDE progressed to PDR in FAME, 31% at 3 years. And again, very, very similar numbers to the monthly ranibizumab-dosed arm progressed to PDR in the fluocinolone dose patients. Remember, these patients are receiving 1.5 injections over the course of 3 years, with 12% at 2 years and 17 to 18% progressing to PDR at 3 years. So a remarkable reduction in treatment burden and clearly very similar, if not identical, biologic effect. So the second future that I would put out there are the Me Too's. I think these are going to come to clinical fruition. Brolucizumab, certainly, and Abicipar, hopefully. So how are these different? Well, at that point, if both of these become clinically available, we'll have 5 anti-VEGF agents, 4 of them FDA approved, bevacizumab being the only one not FDA approved for any ocular use. And the interesting aspects with brolucizumab and Abicipar is that they're small. They're much smaller than the smallest of our previous agents, which is ranibizumab, and that allows you to concentrate them very highly in an aqueous solution, which means if you give a higher concentration, you're going to increase your durability. And we've seen some exciting data from brolucizumab over the last couple of days suggesting that indeed more of these patients can go out at a longer interval. And although it's quoted as a majority, it's still only in the 50% range that can make it out to quarterly dosing. So we do have a ways to go, and hopefully abisapar may be able to take us further. The third category I'd put out there, and maybe the most interesting to me personally, is the dual targeting agents, right? Blocking VEGF works really well. Well, let's find some more agents, and probably the most interesting one and the closest one to clinical reality is angiopoietin-2. So I want to briefly walk you through the biology of angiopoietin-2, because you're going to read a lot about this, you're going to hear a lot about this over the next year especially, but angiopoietin-2 and angiopoietin-1 work on the same receptor, Tie-2. What does Tie-2 do? Well, it basically mediates vessel stability. So when Ang-1 binds to Tie-2, you get strong stabilization of normal vessels. Your eyes are full of Ang-1. In a pathologic setting, you get upregulation of Ang-2. This is where the biology gets a little confusing, bear with me, but Ang-2 is what's called a partial Tie-2 agonist. So it basically competitively inhibits Ang-1. It doesn't let Ang-1 bind as much or as tightly to Tie-2, and therefore you get breakdown and destabilization of the normal vessels in the back of your eye. And there's a thought that there's a synergy between Ang-2 and VEGF-A overexpression in these pathologic eyes, leaky blood vessels, angiogenesis, etc. So there's not one or two, but there's 5 ongoing phase 2 trials. They're listed up here. All of them will have data that's read out and very likely presented during 2018. This, of course, is phase 2 data. Need to emphasize that again. So there's still quite a while to go before these are commercially available. I would think at least 2 years, probably more like 3. Okay, fourth category, drug delivery. These may be clinically relevant in a similar time frame to the dual targeting agents. So here you have the port delivery systems, which are in phase 2 delivery, phase 2 development. Really, Genentech's driving that at this point in a trial called the Ladder trial, which is a little implant that you put in through the sclera, which image is on the bottom right there, and then you theoretically can refill this in the office with a very highly concentrated form of ranibizumab that hopefully will last many months, if not years, in some patients. The other one to talk in a little more detail, and Sinu especially is a specialist with this one, is suprachoroidal delivery of corticosteroids. So this is a steroid that you inject with a really teeny needle, 900 microns, into the suprachoroidal space, which is basically just under the sclera, not inside the vitreous cavity. It's sort of in the wall of the eye. And the hope is that by injecting steroids there, we may be able to see less side effects, less IOP elevation, less cataract acceleration, and maybe an increased durability. But the jury is still out on all 3 of those topics. Here's a video of what that injection procedure might look like. I've done about 30 of these injections at this point, and it is a different mechanism than injecting into the vitreous cavity. It's a little more focused procedure to make sure you get it in the right place. Multiple ongoing phase 2 and phase 3 programs. Any of us are happy to discuss. So the last one are what I call the moonshots, and I definitely put Dr. Keish as a specialist in this regard. These are the things that are, really exciting. This is the flashy stuff. This is the gene therapy. Szilard gave an incredible talk about that yesterday. Stem cells, drops, pills, subcutaneous delivery. These are all the things that are truly disruptive. The only one that I really want to mention here in any detail is AKB-9778. This is the one that I think would make it to market soonest, as long as there's continued to be positive phase 2 and phase 3 data. This is a subcutaneous injection. So imagine you're a diabetic patient using insulin that gives themselves subcutaneous injections every day, multiple times a day. Well, this would just be one more injection for them to give into their subcutaneous tissue, which would modulate what's going to be the Tie-2 receptor, the same thing that the angiopoietin-2 and angiopoietin-1 axis works on. That's exactly where this small molecule works on also. So it activates the Tie-2, it activates the same pathway to stabilize vasculature. And the important graph here to look at on the left is the proportion of patients with improvement in retinopathy severity with, in orange, AKB-978 by itself, in blue, ranibizumab alone, and then in the blue plus orange, the combination dosing. So it seems that subcutaneous delivery is able to reverse diabetic retinopathy severity levels to an identical degree as ranibizumab in this short phase 3 trial. So there's an ongoing, quite large phase 2 trial, 150 patients in three arms. So we will see if that biological signal persists. And then, of course, we will still have to wait for phase 3. So that's a summary of the future data, the future trials and upcoming data that you will see over the next couple of years, I believe, that's going to change the field. At this point, I'll hand it back over to Mike, who's going to drive us.